Well, while she's pulling this up, I'll give a quick plug. The West Virginia Academy of Family Physicians does have a conference going on online right now. So if anybody needs quick CMEs, head over to wvafp.org. All right. Thank you so much, Caitlin. This patient is a patient that I'm fairly close to. I've been seeing her for probably 5 years now, and I see most of her family. I see her grandparents, her uncle, her nieces and nephews, large extended family all come to me. So I really would like to see her have a good outcome, but unfortunately, I don't think that that's in the cards for her unless we make some drastic changes. So she is a 44-year-old female with a history of long-term alcohol abuse and hepatitis C. She has a really interesting story. She used drugs for about 9 years. She was in a very abusive relationship, and her husband was an IV drug user, and they used drugs together. And when she finally got out of that relationship and got away from him, she gave up drug use, specifically IV drug use at that time, and has not used IV drugs for many years. She has continued to use alcohol, unfortunately, and she sees that kind of as her way to unwind in the evening, and she sees it as her kind of her escape, but also something that she does with her kids when they come over to watch football games on the weekends. It's drinking beer is the normal thing to do. So I've been trying for several years to kind of get her to come in consistently and get the information that we need. And just in the last year, she started to feel pretty crappy. And so she started to come to the doctor a little bit more, and we were able to finally get some lab work on her. So she has got a number of medical conditions and taking a number of medications that you can see there. I won't go over them in detail. If you want to kind of keep scrolling down, we'll get to her lab work. And I'm going to skip around on her lab work a little bit because it's easier for me to look at from the EHR. But the big change with her recently was she had a fairly good drop in her platelets, and we've been kind of working up her liver disease more in depth lately. As you can see, her platelets dropped to 91. So for our liver disease patients, it always makes me worry that they've become cirrhotic. Her INR is still fine, which is good, but her AST has really gone up quite a bit. It was 231. Her ALT was 72. Last time I checked it before these labs, they were both less than 100, elevated but less than 100, and her bilirubin has gone up a little bit too. If you could scroll down a little bit more. The thing that I found pretty darn interesting about her, though, was the fact that her ferritin level was over 1,000, and her fibrosis marker, we had actually struggled in the past to get her fibrosis marker because her GGT was always really high, like 600, and we found that the GGT was related to current drinking. And so I kept trying to, I kept repeating the GGTs, trying to find one that was lower that we could get the FibroSure to work. We tried for a long time to get a fibrosis score through one of the GI docs, but we couldn't get it to go. So finally the fibrosis marker worked this time, and we found out that she was cirrhotic. Her fibrosis score was F4. And that wasn't super surprising to me, considering that the AST and ALT had jumped and her bilirubin had gone up a little bit. So I think what makes her kind of a interesting patient is the fact that she is still actively drinking. As of the last time I saw her about 2 months ago, she was still drinking. She's trying to cut down, but she is still actively drinking. And also the fact that her ferritin level is quite high. So what I'm worried about with this patient is what can we do to really lower her MELD score? So her MELD score right now is 10, which is, of course, the point where I would normally transfer the patient out to hepatology to start thinking about transplant, where to go from here, but she is still actively drinking. So I did start her on some naltrexone. I put in a referral to psychiatry to try to do as much as we can to get her off alcohol. I know the naltrexone can have adverse effects on the liver enzymes, so we're watching that. But my big question is there a contraindication to going ahead and treating her hepatitis C? I know she has a lot of other stuff going on, but are we going to cause her any harm by treating the hepatitis C? And would there be benefit there? Considering that she has this ongoing alcoholic insult to her liver. And also, what the heck do I do? I know that the elevated ferritin is probably related to the alcoholic cirrhosis, but is it contributing to her liver getting worse? And would doing phlebotomy help her? We're checking for hereditary hemochromatosis, but she hasn't come back in to have that lab drawn yet. So that's kind of where we're at. I'm happy to have any input that anybody has.
Awesome. Thank you so much, Joanna.
Mm-hmm.
I know it was an intense case, but really appreciate bringing it. And I'm going to open it up to all of the rural primary care docs and providers. I know we haven't done this in a while, but feel free to share your thoughts, and then we'll move on to the hub. All right, moving on to the hub. If you guys want to unmute yourselves and just chime in.
Hi, this is Jean. Can y'all hear me? Yes. Perfect. So I would be concerned about acute on chronic Lennox cirrhosis with this lady. You said her LFTs have increased significantly, and the AST is elevated in a pattern consistent with alcoholic abuse at the current. So if they were lower in the past, and we know that she has cirrhosis, then she likely has acute on chronic inflammatory alcoholic liver disease. So I would be more concerned about the alcohol getting her to stop that than I would be worried about treating the hepatitis C at this point. I think hepatitis C would definitely be advantageous treatment for her. It would definitely slow down the progression of fibrosis into a decompensated state. But if she's having this severe of alcohol abuse that it's affecting the inflammatory response in the liver, then I would address that first. I just wanted to touch on a couple of things, if y'all will indulge me here for a minute. Her MELD score is a 10. 10 is considerably low of a MELD score. A perfect MELD score is 6, so 10 is not bad at all. I don't see creatinine on here anywhere. Oh, yes, I do. 0.5. Okay, perfect. So, I mean, I really feel like her MELD score is being driven, primarily just as an underlying inflammatory response. And that being said, that ferritin being elevated like this has nothing to do, has nothing to do with hemochromatosis and does not require phlebotomy. Until that HFE comes back, I wouldn't absolutely not do phlebotomies on her. Elevated ferritin can be elevated with just about any necroinflammatory liver disease. So fatty liver, alcoholic liver, hepatitis C, hepatitis B, all of these things are going to drive an elevated ferritin level. So that by itself does not warrant phlebotomy. Another concern that I have on her is her BMI is only 15. That's severely malnourished, and these meds for hep C, I'm concerned would cause additional damage for this lady at this point. I mean, I feel like she's pushing decompensated state even though her MELD is low and she doesn't really have like fluid overload or anything like that from what you are saying. But I'm worried that this would push her into a decompensated state, and that would, she's not going to qualify for transplant because she's drinking. So that would really be detrimental to her. Okay, I think that's all I have to say.
So I want to point out one thing real quick. Caitlin, do you mind pulling her labs up again for me? So the ferritin was high, but her iron saturation was also very high. Um, I cannot find the iron saturation. Nope, not up there. You know what? I'm going to find it in our EHR and then I'll spout it off to you.
It says it was 54, now it's 68.
Okay, yeah. So that's the other thing that that was a little high too. And I don't think that takes the ferritin into account, if I'm right. It takes the serum iron and the TIBC, right?
Correct. However, this can be driven by alcoholic liver disease as well.
Right, but my question is, even if it's being driven by alcoholic liver disease, is it causing liver damage?
No, because if she doesn't have hemochromatosis, she's going to be able to break this down. It's just that it's getting backlogged because she has cirrhosis and she continues to drink.
Gotcha. Okay.
Thank you. Thank you for all the input.
Joanna?
Oh, yeah, go for it.
Hey, Jean. Boy, was I happy you're here today, Jean.
Hi, thanks.
Joanna, did she get any imaging procedures?
She has an ultrasound, I believe. Let me see. Yes. Give me just a second. I'm pulling it up.
I'm just curious if it demonstrates the morphology of.
So the impressions was fatty infiltration of the liver and gallbladder sludge.
Okay. You know, the point, and Jean, you can help me out on this one too. When liver biopsies were more of a thing back in the day, they would stain for iron on them and give us a sense if a patient's liver had excess iron in it. My understanding is that a lot of that you can do now with non-invasive MRI. I'm not looking at, the alpha fetoprotein's probably okay. I didn't look at what your answer was, but you know, there would potentially, because this lady, I agree, she has high ferritin and her percent SAT is so high that if you follow those algorithms, you do HFE testing and then sort of, you know, most importantly, eliminate whatever insults are occurring to the liver and then kind of go from there. But Jean, do you have any experience or comment on the MRI to assess liver iron versus the old liver biopsies we used to get reports back?
I think that the MRIs don't give us a real good picture about liver iron. I think that the best way to determine whether or not she would need phlebotomies is liver biopsy, but I wouldn't jump into liver biopsy until we had those genotype mutations back. Because if those come back negative, then it doesn't matter. And the reason there would be iron elevation is because of the alcohol. So if you take away the alcohol, then that would resolve on its own. And you could even demonstrate that if she stops drinking for 3 to 6 months and then you retest that iron saturation and ferritin, it should go down.
Thanks for the commentary there. You know, just as a big picture, I'm not gonna, I think Kaylee has a comment about whether or not we should treat the patient at this point. But if you were to choose treatment, and I agree with Jean, I'm a little nervous this lady's teetering with regard to compensation. Certainly her bilirubin and PT and albumin look okay, but she's close, it sounds like. And you probably want to err towards staying away from protease inhibitor based regimens. In my mind, I'd probably want to use Epclusa or Harvoni. She's a genotype, I think it was 1A.
Yes.
Yeah, so she'd probably, you know, benefit from if we decide to go that route. And when I personally would go that route is if she refuses to stop drinking and doesn't want to come to, you know, the realization that she needs to change her own life. If she's not willing to help herself, we can try to help with whatever degree we can. But that's an opinion on my end. Kaylee may have a slightly different approach. What would you have any comments on that one?
I have a couple comments. Can you guys hear me okay? Because we're kind of sharing the mic. So You know, even without using protease inhibitors, remember that, you know, all of the agents at this stage, you really can still have acute liver decompensation. So there's really not an option that's going to be without risk, although certainly, you know, our NS5A inhibitors are going to be a little bit, hopefully more protective in that regard. But I did want to bring up a concept of MELD purgatory. I think I've brought this term up maybe in a didactic session previously, but if you remember your MELD calculation, really the idea behind it is it's supposed to estimate your prognosis of patients with advanced liver disease and really prioritizing them as far as when they're going to be ready for transplant. So on the transplant list, who gets prioritization? Her MELD right now is 10. Generally speaking, you know, you kind of get into this rough area. And again, this is an individual case, but just kind of think of this general concept. When your MELD score gets above, you know, 15, even above 20 in the setting of alcohol-related cirrhosis and untreated hepatitis C, even if you opt to treat the hepatitis C, you may not improve the MELD score well enough that you're going to, the patient's going to qualify for a transplant. So if they have a MELD score of 17, you treat their hep C, they still have a MELD score, you know, it drops down to 12. It may actually lessen their likelihood of getting a transplant sooner. So you may actually be harming the patient in that regard. Now, again, in the setting of alcohol too, that's going to be playing a huge factor. And my approach in that regard is, you know, if I have a patient that's not cirrhotic, but that is drinking, you know, intermittently, but they don't have advanced fibrosis, you know, I tend to work a little bit harder to treat their hep C as they're working on their alcohol. If they're already cirrhotic with this advanced disease, and it's, you know, alcohol related as well, I don't really know how much benefit we're really going to give the patient to prioritize the hep C treatment if they're not willing to help themselves. So again, it's up to your opinion and your patient and how you want to do your approach. I mean, it's going to be a joint decision with you guys, but that's basically my input. Jean did an awesome job covering everything well beyond what John and I would have. Yeah. So thanks, Jean.
Great, guys. I really appreciate your input on this patient. I think she, you know, I think she has a willingness to help herself. I think she just is, she's struggling with longstanding addiction, and she's got a lot of, we don't have great resources. For instance, I can't get her in an AA meeting that's within an hour. So, you know, it's a struggle. So, you know, I'm going to take what you said to heart for sure, but we're going to work hard on the alcohol over the next 6 months or so, and hopefully by then she'll be doing better.
Great case, Joanna. Thank you.
Thank you so much.
Thank you so much, Joanna. We had one other comment chatted in for us about this, just saying maybe missed her Hep B status. Says West Virginia and some other states have had Hep B outbreaks in persons who inject drugs. I think this lady hasn't done drugs in quite a while, right? So
yeah, it's been a while since she was actively using, and we definitely checked her Hep B status. Hold on just a second, I can double check it here. But Hep B surface antibody reactive. I want to say she's core positive, maybe.
But thank you, Dee. That was a great comment. Definitely keep an eye out for that in our current populations.
Yeah, she was core, I believe she's core positive, Hep B surface negative, surface antigen negative, surface antibody reactive. So she's got natural immunity.
Perfect. Thank you. All right, guys, we're going to move on to the next case. So we have time. Jen, are you ready if I share it?
Ready.
All right.
This patient is not even half as complex as the one that Dr. Bailey just presented, but there is a similarity in that in that I'm concerned about whether or not this is the right time to treat her Hep C. And I will also start out by saying that she's sort of the opposite of Dr. Bailey's presentation in that I have only met her in person once. And I don't have a great, I don't have a great feeling for her as a person. In fact, there was something a little bit odd in the visit that I can talk about in a minute. So I don't have an established relationship with her, although I have spoken to her twice on the phone since then, on the phone, because that's how we're doing things now. So she is a 23-year-old Caucasian female. She has a normal BMI. I got her diagnosis of hepatitis C. By the way, I may be a little rusty on her clinical details because I saw her in March. But anyway, here's the case. She got her diagnosis of hepatitis C 4 years ago and was never treated. She recently, in December of 2019, started in a Suboxone program in Summersville, which is north of where I practice. And at the time I saw her, she had been off IV drugs for 9 weeks and seemed extremely committed to her recovery. She had started using heroin at age 17 IV, and had been using until a few months ago. So even though she was really felt very certain that she was committed to her recovery, that to me represents really a very short amount of time to be in recovery, and I'm concerned about possible relapse for her. She also was using meth until 9 weeks prior to when I saw her. She does not drink. She is a current smoker. She had her first pregnancy at age 16 and has 1 child. She had a non-professional tattoo at age 16, and blood transfusion. She had previous partners who likely were Hep C positive. At the time, she was unsure about her Hep A status and thought she might have had Hep B vaccination at one time when she was incarcerated. She is married, and her husband does not have any history of IV drug use. He was getting tested for Hep C. They were not using contraception, and so I talked to her about, and she agreed to start Depo. They actually had been wanting to conceive, and I said, why don't we get your Hep C treated before you have a baby? And so they agreed to that. The husband was with her. He was present at the visit. And so they both agreed to that. So she's on Depo currently. She is treated somewhere else, I can't remember where, for depression and anxiety, which are both stable. She has an overactive bladder diagnosis, which I didn't really talk to her about when she was in the visit. I didn't realize it until I was actually preparing the case. The physical that day was without abnormalities. You can see her medications listed there. I think the Suboxone is once a day. I'm not sure, it might be twice a day. Okay, so labs. Her CBC was normal. Renal function and glucose were normal. Her AST, I didn't put down the normal here. That might have been a tiny bit high. I could look at what our high normal is. It might be 40. But other liver enzymes and bilirubin were normal. You can see her iron studies were normal. Her vitamin D was a little bit low, so I've started her on weekly 50,000. I use a vitamin D. AFP was normal. HIV negative. She was genotype 1A, 4.6 million viral load. I don't have any previous Hep C viral load or viral load. her serum fibrosis marker put her at a fibrosis stage F0 to 1. And her APRI 0.4, child Charcot-Pugh class A, and MELD score was 2. So as you can see from my notes and from my introduction, that my main concern with treating her is that she's closer now, I guess, to 5 months of her recovery. And she said, I've spoken to her on the phone since I prepared the case, and she was still taking Suboxone, had not relapsed, and was feeling like she was solid. And she actually mentioned her husband to me as one of the reasons that she got into a Suboxone program and stopped using IV drugs. It was a fairly odd encounter. It was the first time I had met them. She seemed to have a really odd affect to me. She was extremely quiet, and she often turned to him before she answered a question. And not to sound judgy, he was quite a bit older than her. I would venture a guess about 20 years older than her. What I found out afterwards from one of my colleagues is that he is illiterate, and they had just attended a visit for him in which she answered a lot of the questions on his behalf to the physician. So the dynamic was very odd. And on the phone, when I call her, she's more readily answers questions, but he's in the background. I'm not really concerned about abuse. I actually just feel like they're very close. But it's interesting just that I don't have a relationship with her, and this question about her maintaining her sobriety is what I'm concerned about. Let's see. At the time that I prepared this, I was curious about whether or not I should get an ultrasound. I actually got an answer from Kaylee on the case, and she didn't think that was necessary. Let's see. So I didn't get Hep A and B labs at the initial visit. It was just an oversight, and we also didn't start her on vaccines. I don't have it in my notes, but I think she refused at the time, or something like that. But at any rate, her Hep B, all of her Hep B titers were negative. So surface antibody, surface antigen, and core antibody were negative. Her Hep A antibody was positive. So I guess since I prepared the case, one of my questions is, she has antibodies to hepatitis A, do I need to vaccinate her? I would think not. It sounds like she contracted it somewhere and now has antibodies. So we have recommended Hep B vaccination. We'll get that started. Obviously, if I treated her as I listed there, I would either do Epclusa for 12 weeks or Mavorite for 8 weeks. And that's my case.
Thank you so much. So first I wanted to ask Rachel if there was any drug interactions with Zyprexa. I saw that was the last question listed, and I wanted to make sure to get that out.
I think I got a no on that from somebody, but I'd love to hear from Rachel, either Rachel or Kaylee.
Yeah, they're okay with both Epclusa. No interactions with Epclusa, Mavorite, or the Zyprexa. So you'd be okay from a drug interaction standpoint with her medications in either one of those regimens.
I just want to say one more thing about this case. So my fear with her, I don't have an established relationship with her, and I'm working on that, and I've had 2 follow-up contacts with her. My fear with her, she's so eager for treatment. My fear is that if I don't treat her, that I'll lose her, and maybe I'll lose her to somebody else. She'll go to somebody else just fine. But I want to make sure that I'm doing the right thing for her, and I really think that it's going to be a delicate conversation about, do we try to wait a little while into her sobriety, because I don't want to seem that I doubt her. I don't. I just know that addiction is a powerful disease and that the risk is there for relapse.
Great. Jen, you did an awesome job, and we really appreciate the case. I'm going to, again, ask any of the rural providers if they want to jump in. Comments, questions, impressions.
Jen, when did you say her original diagnosis was? Like when was
4 years ago.
It was 4 years ago.
Yeah. I think that might have been when she was incarcerated. I think I'm remembering that right.
All right. Anybody, just go for it.
Hey, Jen. It's John here. Jennifer.
Hi, John.
Sorry, I didn't mean to call you Jen. It just feels so familiar. Jennifer. Sorry.
You know, no, I like Jen. I had an aunt who called me Jen, so anybody who automatically calls me Jen reminds me of my Aunt Jane.
You can call me Auntie John any day.
Auntie John. Auntie John.
So, you know, I think that our job is in a situation like this is communication. And if we step back and say, why are we so hesitant to treat somebody who might relapse? Those reasons are not biologic, and they're economic. And anytime that's the answer, my apathy factor goes up to like a 10 when it's economic. So, and I hope there's no one from Medicaid on this call. So what I mean by that is, you know, you have an engaged patient who's freshly married who wants kids. That's a bunch of motivation. Dr. Feinberg can tell you about her study that she and Kaylee are involved in, where they treat active users, and even she's not even an active user; she's a freshly recovered user. So I think you have a captive audience, and what I think our job is more than anything is to communicate the current culture of one treatment per lifetime, and put the ball back in her court and be like, hey, there's this silly rule right now that says you can get treated one time in your lifetime. This doesn't mean the treatments wouldn't work a second go round. It means that there might be an economic challenge getting treatments the second go around if you were to relapse. So communicate the seriousness of trying to stay sober, the potential benefits for lack of transmission to baby, and the benefits to her health. And but just do communicate those limitations, I think, on the one treatment per lifetime. And if she thinks now is a good time, it's my own personal approach in these patients is to be as non-paternalistic as possible. If they tell me they're ready to go, I say, all right, I trust you. You know, you're here for my help, I'll help you. So, that's probably what I would do. And I love your treatment choices. Either or sounds fine. You know, she's somebody who, I commend you for putting her on a progesterone-based contraceptive as well, so that there's no issues with the protease inhibitors interacting there. So either one's an option with the progesterone-based contraceptive. So great job, good management. I think if she wants to go for it and tells you she's ready, I'd go for it.
Okay, great feedback. Thank you. She certainly seems really strong in her commitment to her recovery. So,
Jen, I think you're given a perfect segue into the didactic today.
awesome.
So I'm glad this is why when you presented your case, because I was hoping we'd go in this order since it's going to kind of correlate with what I'll talk about today.
Good.
Well, awesome, guys. Any other questions, comments about this case?
Oh, and then, I mean, is she immune to hepatitis A? She's got antibodies. Are those lifetime?
She is immune. This is Kaylee. She is immune. I wonder if maybe she did get vaccinated while she was incarcerated for Hep A. The jail system is tending to do that now. Okay. Or she's young. She may have had them as a child as well. But she is immune. I don't tend to repeat titers with Hep A vaccine just because the response rate is so high. I mean, it's over 97%. So I wouldn't necessarily feel like you'd need to repeat those, but yes, she is immune.
Okay, thanks.
Awesome. Kaylee, I'm going to launch right into your didactic, if that's okay. And if anybody has questions, you guys chat them in and we'll get to them at the end.
I think she's going to control it. Are you going to control my slides, Caitlin? Because I'll probably, can I do it?
You can. So Mitra and I recently learned this lovely new Zoom function that we're only giving to people we really trust.
That's not me because I've never presented through Zoom. So
I can control them if you like. That's no problem.
It's okay. I can try. If it doesn't work, I'll just bounce it back to you. It's
Okay, so what I'm going to do is give you remote control access. I'm going to start it, and then you should just have to click, okay?
Okay, perfect.
So try it and just let me know.
Okay, good. How do I go back?
The left arrow at the bottom right of the screen.
Oh, that one.
Oh, now it's ruined. That's it.
Take it back, Caitlin.
That's it. All right.
Anyway, so I'm so excited to talk about this topic today because I don't think we've ever discussed this, or at least not in detail. I wanted to talk about the promotion of safer injection practices for our patients who inject substances. And so the objectives today, I'm going to fly as quickly as I can to get this done by 12:15, but I'll stick around for a little bit if, with questions or to explain any further following if you guys have time. But I wanted to recall the concept of harm reduction, identify the complications and mechanisms of harm from injection drug use, examine the injection preparation as a means to identify steps to make this process safer for the patient, and also to understand the appropriate disposal methods of injection drug equipment. So harm reduction, we've all talked about it, and typically when we refer to harm reduction, we tend to talk about either medication-assisted therapy or opioid substitution therapy, syringe service programs or syringe exchange programs, PrEP services, those sort of things. But basically, this is a public health approach that serves as an alternative to abstinence-only guidance, utilizing multi-component interventions. So think of this as, it's really a packaged approach. It's not just one intervention. Ideally, it's a one-stop shop, including all of the interventions listed below, including syringe service programs, HIV viral hepatitis testing, PrEP, linkage to healthcare, including mental health, MAT, naloxone, vaccines, fentanyl test strips, and safer injection education, which we don't really talk about. So utilizing all of these strategies really increases the likelihood that people who inject drugs will use health services based on the status of their drug use, rather than coming in based on the status of a disease or having an infection or complication from their drug use. This also, using these strategies really reduces complications from injection drug use, as well as reduces new HIV and viral hepatitis infections. It's not an attempt to minimize or ignore the real harm associated with drug use, but as providers, remember, it's a privilege for us to treat all of our patients, regardless of where they're at in their walk of life. And so we have to understand that this is already intensively stigmatized behavior. People are actively engaging in it. They may continue to engage in it. Not everyone is going to have access to a syringe exchange. Not everyone is going to have access, or it may not be appropriate for them to engage in MAT therapy. So our role is really to drop some knowledge and support them through the process of their drug use, and not only support limitations for the patient. And really, by doing this, we're really empowering patients to be peer educators and to support each other in strategies to reduce harm. So this was taken from the WVDHHR website. It's a US map, obviously, and it's showing vulnerable counties in the US for HIV and hepatitis C outbreaks, as well as locations of syringe service programs. And as you can see, throughout the nation, West Coast is rocking, Upper Northeast is rocking. They have a lot of access to syringe exchange or syringe service programs. And where it's consolidated, the counties that are most vulnerable, West Virginia really comprises a lot of those vulnerable counties, and we really do not have many syringe service programs in the state. So let's see. So some complications, this is not a comprehensive list, but it's the ones that I could rack off my brain quickly last night when I was making this. So there are very numerous and serious health complications associated with injection drug use. I'm not going to list all those for the, considering time. Endophthalmitis is one I left off of that list just glancing at it, but there's a bunch of things that can go wrong with injection use. Obviously, some pictures, because visuals are always helpful to me. This looks terrible, absolutely terrible. So endocarditis, if you want to actually see how it looks on the valve, viral hepatitis, or I'm sorry, this is HIV, but also other viruses. This one where you can see the bone, there's a little arrow with this is a retained foreign body, and then obviously a lot of skin soft tissue infections. So some nasty visuals. So mechanisms of harm, I really tend to break these down into 3 categories. You have substance-related harm, hygiene-related harm, and technique-related harm. Substance-related harm, we won't spend too much time talking about that, basically because that's the least control that the patient has over safer injection practices. It really depends on where they're getting their substance from. They can't control the purity or the quality of their substance a lot of times. It's whoever gives it to them or however it's manufactured. Certainly if it's a prescription drug, it's going to be a lot higher quality than buying it from a dealer. There's a lot of additives, contaminants. You'll hear people say they got into a bad batch and had a bad reaction. But so this is kind of the one that we have the least control over. Hygiene related and technique related are the 2 I'm going to focus on today. I've been a nurse for over a decade, and so these infection control practices are really something that I've been doing for quite some time, and I think as healthcare providers we all have. And so really this is just translating it to community practice and community education. So I'm sure everyone knows how to inject drugs because there is actually a lot that goes into this. It's very complex, and I watched a lot of YouTube videos about it, and I'll try to do my best. So if I'm wrong, please correct me. But this was the most comprehensive picture I could get that had all of the injection equipment, or most of it, in one document. But basically, your injection equipment consists of the surface that you're going to be injecting with, the drug. This could be a powder. Usually it's a powder form. It can be liquid. It can be crystallized form. It can be a pill that's crushed, but you have various formulations of your drug. Your cooker is usually a tin device or a metal device used to prepare your works. It's typically a spoon. It could be a bottle cap. It could be the bottom of a soda can. It could be, if you have access to syringe exchange, all of these works are really pre-packaged and sterile. But in this instance, we're going to assume that you don't have access to that. Your water source, used to mix your drug so that it becomes liquefied, and so you can inject it. Sometimes we use it, or you use an acidifier. We'll talk about that. The heat source, a filter, your needle and syringe, obviously, tourniquet, alcohol swab, Band-Aid, for after you've injected, and then if you're not able to use sterile works every time, bleach, cups, and then a disposal device. So a whole lot of stuff to make this a successful event. So really understand that the injection process is multiple opportunities for exposure to infection. I broke it down into 14 quick and easy steps for injecting drugs. But as you can see, I mean, it's a lot more intensive than what goes on through my mind when I think about someone who's injecting in my stereotypical experience. So first step, wash hands. Second step, gather all of that equipment that I listed on the last slide. Next step is prepare your surface. So you could clean the surface with bleach and water. I'd usually say 1 to 10 parts dilution of household bleach and water. Also, you could set down a mat or newspaper, magazine, brochure, some kind of surface that's going to be where all of your works and injection preparation equipment is set out. If you set like a placemat or some kind of setting down, then it's also easier to dispose of afterwards. And then also if they happen to drop their drug, it's going to go to that confined area rather than just dropping somewhere or splattering on the counter or the floor. So I would recommend that. Next step is you add your substance to the cooker. Again, different substances have different solubilities. So even heroin, there's varying types. There is powder heroin, there's black tar heroin that needs to be heated. Some you can just mix with water. If it's a pill that needs to be crushed, you may not be able to get it in full powder form and still have some of the tablet fragments left over. If it's cocaine, crack cocaine needs to be handled differently than powdered cocaine. So it really does depend on the substance also as to how you prepare it. Next, you'd add your water source, and sterile water is certainly ideal. If you don't have access to sterile water, boil it for at least 10 minutes. Remember that, and teach your patients, bottled water is not sterile. Sterile saline is also not ideal because saline, it makes it a little bit difficult for certain substances to dissolve. So they won't dissolve in saline. You know, these two are probably the best options. This one certainly, the best options you would have. Also note that, tell your patients when they're boiling water, it needs to be used soon. So don't boil your water and then leave it stagnant and use it 2 days later, or you're gonna also again have opportunities for microbes to contaminate that source. Next, you could, in certain instances, you'd need to add an acidifier. This is typically used with certain types of heroin or even crack cocaine because these are water insoluble alkaline substances. In some instances and with syringe exchange programs, they may have citric acid or ascorbic acid little packages, almost in like a alcohol swab. It kind of looks like a little tiny package as your acidifier, but a lot of patients may just use lemon juice, vinegar, substances like that. And so this also puts you at risk of having a lot of irritation and trauma to your veins if you're using too much. The next step is you heat your drug up. So whether you're using a burner on a stove or you're using a lighter, but you would heat the cooker so that the drug would liquefy. In some instances, you'd need to use a filter. So if there's any particles left, it hasn't completely liquefied, you'll note that some patients will say they're using a filter. You put that in the cooker. A lot of patients use cotton. Ideally, you'd purchase sterile cotton. Things like cotton, cigarette filters, lint, those kind of things certainly have lots of contaminants. If you've ever heard or seen of a patient with cotton fever, sometimes you get it's, we kind of think of an Enterobacter with cotton fever, but it presents as basically a sepsis that's self-limiting and resolution usually within like 24 to 48 hours, but they get febrile, leukocytosis, just really, really, really sick. But get $1 million workup if they present to the ER. A lot of times they don't because they can recognize this. But get $1 million workup, everything's negative, in a day they feel better and go home. Next step would be insert your needle into the filter and then draw your preparation into the syringe. Remove the air bubbles by putting your syringe upwards, and then you usually tap to get the air to go to the top of the syringe and inject that air out. And then choosing your injection site, cleansing that injection site with an alcohol preparation pad, inject, and then dispose. And that's it. Injection 101. So general principles to reduce hygiene-related complications, because that's a whole lot of steps. So easiest thing is ask your patient to walk you through their process. What do they do? Because that'll help you know what areas they need help in. I've had patients that they really felt like they were being very hygienic when they were injecting, and then come to find out they were missing a step as simple as just wiping their skin off with alcohol, or they were using tap water and not boiling it. So try to identify what steps they may need help with to reduce harm. So best case scenario, certainly one shot, one time, every time, using one new sterile needle, syringe, all of your works, sterile once every single time. Not sharing any part of your injection works, and then specify not even sharing your water source, cooker, etc., because those can also be nuisances for infection. If you must share equipment, split the drug, the water, and the filter before use. So don't wait and draw out of the same equipment, split it up before you would use, and then use it separately. There's also a couple concepts, backloading and front loading I have a slide about. And then if you don't have access to needle exchange, I'll have a slide about how to bleach your works. And that is not just your needle and syringe, but also your cooker if you need to reuse it or share it. So backloading or piggybacking and front loading. This is a method if a patient is intending to share their drug. So ideally you would divide the substance up before you would plan to inject. And so preparing it separately using separate works, not sharing those works. In some instances, if for whatever reason that's not plausible, one method is called backloading or piggybacking. In this instance, you'd need to have 3 syringes. The first syringe would be the one that's used to draw the drug up. And then you would remove the plunger. So this is patient 1, patient 2. Remove the plunger, inject half of the substance into one, inject half of the substance into the other, and then replace both plungers. So neither one of these syringes have come in contact with either patient. This is the one that was used for both. The other concept is called front loading, which is kind of the opposite. So instead of putting it down the back of the syringe, you would take your drug preparation syringe and then inject it. And again, ideally, this is a sterile or bleached syringe, inject it into the front of the syringe. This would only work really if you had one that had a detachable needle. So a lot of times patients may use TB syringes or insulin syringes because those are easier to access. And so they wouldn't be able to detach that needle. So this method is not, probably not as commonly used. So how to bleach your works. Again, this is second best, but a lot of our patients don't have access to sterile works. So if you must bleach your works, if they are to be shared or if they're to be reused, there's a pretty methodical process to still greatly reduce harm. You'd need 3 containers. So whether it be 3 separate cups, clean cups, I'll just say plastic, red Solo cups, clean ones. Oops, I don't know how it backwards. Your bleach, and then a clean water. First, you would take your syringe, and the first container is water, second container is bleach, third container is clean water, not the same as this clean water, okay? So fill up your syringe with clean water, tap or shake your syringe for 30 seconds, and then discard the water from that syringe either in the toilet or the sink or a separate cup, but not back into this cup that you're going to be using. So you repeat these steps a couple times, usually until you can't see any blood or substance in that syringe anymore. Then you're going to disinfect it with pure bleach. So in the second container is where you have your bleach preparation. Draw it up again, tap or shake it vigorously. This says 30 seconds. This is from the CDC. I've actually read reports where hepatitis B, really to decrease that chance if there's hepatitis B in this device, it really needs to be shaken vigorously for 2 minutes. HIV, to inactivate 30 seconds should suffice. We don't really have any idea how long you would need to vigorously shake that bleach preparation for hepatitis C to be inactivated. And then discard your bleach from the syringe. You can also repeat this step as well if you wish. The third step is after you've bleached it, you need to rinse it out with clean water. It's the same premise as the first step, so I won't repeat it, but you're going to discard that water as well. And then also just keep in mind things like viral hepatitis, HIV doesn't necessarily have to be your syringe or your needle. It could also be your cooker. So make sure that's really cleaned with bleach and water as well. So technique related complications, this is how you're injecting. First is more related to what you're injecting. This is more the method. So understand how equipment selection and injection technique preserves your vasculature. So like I said, tuberculin or insulin syringes are commonly used. Usually it's a 25 to 28 gauge needle. It's 1 cc syringe. These are super tiny. And then usually the length of the needle is like 5/8 to 1/2 an inch. So really tiny. I mean, these are insulin syringes, tuberculin syringes. These are the best option just because you have your less risk for vessel damage. So your puncture site's going to be smaller. They're not going as deep, so you don't have you're less likely to perforate the vessel. Sometimes people don't have that option and they're using a 14 gauge, which is huge. So also using a soft, flexible, easy to open tourniquet, and then remove once you've registered. So once you've inserted that needle, but before you actually inject the substance, and that's to prevent trauma to your vessel. Medical grade tourniquets, those are hard because those are really intended for me to use on a patient. They're really hard to utilize for a patient to use on themselves. Some patients might use a shoelace or a belt or a rubber strap or something as a tourniquet, but really that's to kind of pump up your vasculature. So also helps prevent your veins from rolling. But you can either teach patients kind of to run their injection site under warm water, really hydrate, exercise, pumping your fist, lowering your extremity, tapping the injection site. All of those things can kind of increase your chances of having your vessels bulk up so it's easier to access. Make sure you're using a sharp, sterile needle for every injection. This picture right here is just showing you, this is a microscopic picture of what happens. Fresh needle, after 1 use, it's already deteriorated. After 6 uses, there's so many burrs like that. It's no wonder these break off on people's arms. It's no wonder that there's, people say I have no veins. It's because of this. Some patients might try to sharpen their needles on like a matchbox or a surface. That actually makes this more likely to happen. So just be mindful, as much as you can to not reuse. Alternate and rotate your injection sites, remove air bubbles, insert the needle in the direction of body's flow at a 15 to 35 degree angle with bevel up. Aspirate for blood return to make sure you're in the vessel, inject, and then apply pressure after injection above injection entry site to stop any bleeding. Injection sites, to talk with your patients about kind of on a hierarchy, which is more safe to inject and less safe. So more safe, typically your first choice is going to be veins in your arm, median cubital vein, cephalic vein, basilic vein, but arm veins, these are big, so they're easier to access. Whenever I was learning phlebotomy in nursing school, we were taught to kind of start at the lowest point and then move upwards, because if you damage this vessel, you're damaging everything below. That's because we've been trained and practiced. Hand vessels are so much smaller and they're so much more delicate. So this would not be where you would teach an injector to start off first. The other kind of benefit of injecting up in this area, if they need to, is if there's track marks or bruising, it's, you know, you can cover this a lot easier than you can cover these. This is more visible. Legs, certainly not ideal. It takes longer for circulation to come down here. So, I mean, I'd say that would be, you know, likely your third choice. Feet, small vessels like your hand, even further away from your heart. So even more decrease or slow circulation. Certainly your groin or femoral vein, super dangerous. It's so close to your femoral nerve and femoral artery. If you guys in med school, you know, had to do central lines, you know how stressful it was because it's a blind stick and you're palpating for the artery and just hoping that you're not going to hit it. And then certainly your neck, your jugular, it's so close to the carotid, can really cause quick death, complications fast. So avoid those if at all necessary. Disposing of injection equipment. So this site, safeneedledisposal.org, I know there's some PA listeners. So I looked up West Virginia, but if you go to the site, you can type in the zip code and it'll bring up kind of what the state practices are or policies are. In West Virginia, you can actually dispose of your sharps in regular trash, not recycling. There's also 2 drop-off locations, Cabell County and Kanawha County, at the health departments that you can dispose of sharps. But what you need to know here is if patients don't have access to a medical grade sharps container, encourage them to dispose of their sharps in a durable plastic container. So glass breaks easily. You don't want to put needles in there. You could use a coffee tin, laundry detergent bottle, bleach bottle. Don't use a water bottle, soda bottle, milk jug, because that's flimsy plastic. So there's a lot higher chance it's going to puncture. When your container's about 3/4 of the way full, cap it, make sure cap's really secure, duct tape the crap out of this so nothing falls out. You can label it, put it in a trash bag. I've heard in some places that they'll, you know, recommend putting it in a trash bag with like kitty litter or use coffee grounds or something to make this unappealing so nobody stumbles across your trash and wants to get into your used works. And then dispose of this in the regular trash. Some resources. If you want a visual demonstration, this is one of the YouTube videos that I watched yesterday that I found very beneficial. There's actually a guide through homereduction.org that's a lot more detailed than what I went through today for injection drug use, you know, making sure safer injection practices, and then a couple additional websites that I used. All right, sorry guys, it went over, but thank you.
That was great. Thank you.
Yeah, no worries for going over. We really appreciate it. And we had great comments in the chat thanking you.
No wonder people get endocarditis.
Yeah, I mean, it really helps you understand and helps you know how to help your patients stay healthy, healthier. It's safer, you know? So it's hard because we don't really talk about that, but it's interesting because you can see why people are getting endocarditis or why their needles are breaking off. So right. I thought it was useful.
Yeah, super useful. Thank you.
Hey, Kaylee, I think it's Carolyn. I think this would be an extremely beneficial lecture for a wider audience.
Agreed.
Thanks, Carolyn. You know I hate public speaking, but thank you. But no, I do think it's useful because we don't ever. I mean, I've never been to a conference or listened to a lecture where they actually talked about this, so I think it's useful. Yeah. Not as much evidence-based, but you know, practical common sense, applying principles of healthcare, infection control to real life.
Right. Look at Kaylee. I also think there's something very more subtle. It decreases stigma too.
Yes.
Instead of saying, "Oh, that's a secret thing that happens up a dark alley that it's not fair to talk about or it's not okay to ask about," just it doesn't normalize it, but it just destigmatizes it.
Well, and the fact that you're open as a provider to talk about this with the patient speaks volumes, because then they're going to know that you care enough to actually think about these things, and you're interested enough in what's going on in their life to talk about this. So I do think that it really, it really makes them feel like it's a safe place if they're coming to your practice, because they know you're seeing them as a person.
My opinion about destigmatizing and having this kind of conversation is pretty similar to that of discussing protected sex with teenagers. Like, I hope that my 14-year-old patients are not using condoms, but I'm going to explain to them how to use a condom so that they can protect themselves.
Absolutely. Yeah. I remember when I was in undergrad, I followed a school nurse, I won't say where, but she was advocating for sex ed, and the county she was in still only promoted abstinence, and she gave me statistics that all but 4 of her high school senior females were pregnant. So obviously abstinence does not work. Neither does the Say No to Drugs campaign people use. And so whether or not we agree with it, it's still our duty to care for our patients where they're at.
Absolutely. Kaylee, this was wonderful. Everybody appreciated it, and I know it was great. I know we're a little bit over, so I'm going to say that anybody who has questions, please just email us, and we'll make sure to get those to Kaylee, or we can address it in the next session. Hep C sessions and HIV sessions are going to continue. We are not going to take them over with COVID anymore. That has been a super intense thing that we are thankfully dialing back to twice a month. If you guys have any comments or anything about that, email us as well. But that's it, and I'm very happy to see everybody here again. We'll see you guys later.
Thanks, guys. That was great.
How often are you needing?